Welcome back, everybody, to the Podiatry Mind Shift podcast. Today, I want to talk a little bit more about getting your own medical office suite, medical surgical suite. In the previous two ones, we kind of did an introductory podcast. Second one was more of a how to staff your practice, and this one will be more let's talk about how we can improve your reimbursements. And one of the best ways to do that is going to be creating your own in-office surgical suite. Now, first off, I will tell you that getting your surgical suite certified to be able to bill a facility fee is nearly impossible. You can have a separate location where you can do a surgical suite, but to try to capture a facility fee by strictly having an in-office surgical suite doesn't work. Medicare doesn't allow it. So it's not really worth your time, in my opinion. If you want to get in with the surgical center and invest there, that's probably a better option if you're looking at that route. But personally, I think there's a lot of surgeries you can do in your office that are very simple, very quick, very easy, that will reimburse you more, right? I remember back in residency, one of the eye openers for me was, here we are going to cover these attending surgeries where we're doing hammertoes, an isolated hammertoe. We're doing plantar fascial releases, all these little simple surgeries that are taking up time in the surgery center or the hospital. And in reality, these can be done in your office. So in residency, I was working on my general surgery rotation, and I remember a woman coming into the general surgeon's office with a very large lipoma on her back. And the general surgeon basically numbed it up and excised it right there in the room on the table. And it was a rather large, maybe size of a baseball size lipoma. He had the adequate equipment to be able to cauterize and do things. And yet we're doing hammertoes in the hospital. It just seems like overkill. About 4 years into opening my private practice, I began my minimally invasive journey. I got involved with TJ On, where I began learning more about doing things in the office, about increasing my wealth and my productivity, which was fantastic. It really helped me grow my practice, and it has flourished since I really started learning minimally invasive. As I've stated in previous podcasts, that I currently have 4 doctors working for me. Most of them do some degree of minimally invasive, maybe not all the procedures that I do, but by doing that, again, we're increasing our reimbursements on those procedures. So for myself, I do bunions, I do hammertoes, I've done neuromas, I've done plantar fasciotomies, I've done distal metatarsal osteotomies for diabetic ulcers, Tailors bunions, exostoses, chylectomies, Haglunds deformities, and more, right? Those are really the big ones that we do frequently. If you're doing these in the hospital already and you understand the concepts behind minimally invasive surgery, then there's really no need to train more. You just need to get the proper equipment in your clinic. If minimally invasive is something you've never touched into, then I would highly encourage you look into the Academy of Minimally Invasive Foot and Ankle Surgery. There's also the International Minimally Invasive Foot and Ankle Surgery meeting in Chicago in July. However, I think the bigger one would be to be involved with an organization such as the Academy of Minimally Invasive Foot and Ankle Surgery, where we draw from all around the world. We've had lecturers from Morocco, from Paraguay, from Spain, from Mexico, Australia, Germany. And so you really get a wide range of people across the world that are doing minimally invasive surgery. Now, minimally invasive surgery, as you know, when it's taught in the hospital, you're talking like the picaplasty or the pica or the mica, where you're using two screws, or the voom. Um, to do it in your office, you can't really do those methods. You have to do the surgeries basically with K-wires or no fixation at all. If your method of choice for bunions is fixation, then you shouldn't be doing bunions in your office. However, if you're willing to try and think outside the box, there are ways to do it. I do mild bunions with what's called a Reverden Isham, and I do my larger bunions with a Bosch or a Siri bunionectomy, which works fantastic. You float your hammertoes, float your Tailors bunions, float your lesser metatarsal osteotomies, and they all do fantastic, right? So number one, let's talk about your setup, right? So setup, you need to have a room large enough to work, right? Number two, you need to have a C-arm. A C-arm is a must. Once you get going, you can do a lot of minimally invasive surgery by feel. It's a lot of tactile feel, so you can do it, but I would not necessarily recommend that. I would recommend always using a C-arm. There's lots of places where you can get a good older mic, like Hologic or similar type fluoroscopies. They do have the newer, smaller ones that have much larger or much less of a footprint, but those are going to run you around $60,000. If you look on eBay or even talk to some reputable imaging companies, you can usually find a good refurbished model C-arm for about $20,000, maybe a little less, right? So that's going to be your biggest expense in getting your surgical suite set up. Number two, you're going to need some sort of low speed, high torque drill. If you contract Arthrex, I think last time I talked to them, it was about $12,000 for their system. There's lots of places out there where you can get what's called an OSADA or an NSK. There's other brands out there that will run you about $3,000 for the drill. You're looking at about $20,000 right there just for your basic setup. You can buy big C-arm drapes. I tend to use just 2 Mayo stand covers. That'll save you a lot of money in the long run, where the drapes run about $20. You're going to spend pennies, basically, or dollars on these Mayo stand covers. You'll need to get some sort of scope drape or similar in order to cover your OSADA drill. For example, the OSADA drills, the cords cannot be autoclaved, so you've got to protect that as far as your sterility, whereas the hand pieces can. So you kind of have that interface, much like a scope. Part of it's, autoclavable, the rest is not. Aside from that, it's just the typical stuff that you need, the bandage supplies, which you probably already have in your clinic. So really, it's just the space, the drill, and the C-arm. There's a really good book out there for learning minimally invasive techniques without hardware. If that is something, I'm going to step back here and grab that. If that is something you are interested in, this is a fantastic book written by Mariano de Prado, Spanish podiatrist, that talks about minimally invasive surgery and techniques that you can use in your office in order to, again, increase your reimbursement. So I kind of just did a quick little dive into my reimbursement or my reimbursements, and I noticed that when I do a 28299, which I tend to do, is the code I use when I bill my Austin Aikens. Again, when I'm talking to Bosch, I'll do the Bosch on every moderate to severe bunion, whereas the Reverden is maintained for really small, isolated, bunions. Again, in the office with the Bosch, if you don't know what that is, it's just using a K-wire or a Siri bunionectomy. I use the burr to cut a transverse cut through the neck of the metatarsal. I shift the head over. I always do an Aiken, and then I place the K-wire. I tend to use a 0.62 K-wire to maintain my fixation without a lateral release. I do not do a lateral release because that'll help kind of lock in that head. Um, I've noticed that when I do it like at a surgery center, my reimbursement is about $650 with most insurances. Whereas if I do it in the office, I'm getting anywhere from about $1,200 to $1,600. I've even had a couple isolated ones that reimburse me almost $2,200. So you're almost doubling your money, if not more, by doing these types of procedures in your office, right? Probably not quite as high when you're talking hammertoes or Tailors bunions, but you're still going to increase your reimbursement. The great thing about these surgeries in your office is also time savers. Doing surgery in your office, there's no waking up and getting to the hospital or surgery center 30 minutes before. You can stroll in at the same time the patient is and have your staff get them ready. You can prescribe a Valium if needed to calm them down. What I tend to do is if in their pre-op appointment, when we sign consent, if they have a lot of questions and they seem really antsy, then we move them to the surgery center. If they seem like they're calm, they can deal with the injections, they can deal with doing everything under local, then we proceed. Again, some of the great things about minimally invasive surgery is you can tell the patient there's minimal scarring, there's no hardware, or minimal hardware if you're going to use a wire. Sometimes I don't even use stitches because the incisions are so tiny you can steri-strip them. They can get up and walk out. There's no general anesthesia. And ultimately, they have a faster recovery. Does that mean that they're healed faster? No, we all know bone takes 6 weeks, but they recover faster because we're not dissecting large amounts of soft tissue away from the bone and we're not making large incisions. Usually when talking to patients about this, that sells them right away. The fact that they don't have to have anesthesia, as a lot don't. They also want the faster recovery. So there's lots of things that you can present to the patient when you're giving them these options for your in-office surgical suite. The other thing is after surgery, patient gets up, patient walks out, you quickly dictate your note, you walk out. There's no PACU. There's no PACU nurses calling you because the bandage is bleeding everywhere. There's no PACU nurses calling you because the patient's in too much pain. That's all managed right here. So it's really an in and out process for the patient and for yourself. So, if you're a person that's doing 5 surgeries in the hospital on a Friday, if you're doing them in the office, you could probably put in 8 or 9 relatively quickly. A Bosch bunionectomy takes me about 15 minutes to actually do it. So about 30 minutes from start to finish as far as prepping the patient to them walking out the door. You're not going to get a 30-minute surgery in the hospital no matter what surgery you're doing. It's just not possible between the delays at the hospital, the turnover times, and all of those things. What else? Let's see, patients. I typically charge a $250 booking fee to use my surgical suite. This is refundable if they don't cancel. I kind of do the same thing for the hospital, but I book this surgery fee in order to keep them on the schedule, keep them from canceling. If they do cancel within 2 weeks because it messes with my schedule, I do not refund that $250, and they do need to pay it again if they want to reschedule. After their surgery and after their global period, once everything's been balanced, then that $250 is reimbursed, or I use it as payment towards whatever the patient owes me back from the insurance. So that's another thing I do. I tend to try to make everything a one-stop shop. I have things like PRP available for patients. I have ice packs available. I have all the DME available. So I have them, walk out with everything they need. Number 2, I carry antibiotics in my office, so I prescribe everybody an antibiotic and a pain med. Obviously, I don't carry pain meds in my office. I prescribe that out, but I tend to carry my own antibiotics. It's a low kind of hanging fruit. You can buy antibiotics a lot of times for $1 to $2 for a 7-day supply, and I bill the patient $5. Very simple, but it's little by little, you're just making a little bit more revenue rather than giving it to the pharmacy. Um, PRP, I charge $1,200 for that. I get patients that want that all the time, so we just give it at time of surgery. That also helps them in the recovery, helps them in the healing time. And again, just more ways to boost your revenue. I also try to sell a laser package or something similar to the patient, again, to help with recovery, help with healing, help decrease edema and healing. I'll also recommend, depending on what type of surgery they have, a reparal compression sleeve to help with that edema control. I usually don't prescribe that till about weeks 3 or 4 in order to let some of the pain and some of the edema go down before wearing that compression sleeve. Most of those reparal sleeves, they're great. Most patients will buy a second one when they come in and start wearing it, just so they have one clean one while they wash the other one. So that's another great source of revenue. And then just carry lots of other things that the patients need. You could do Voltaren gel, you could do EBM vitamins, which I do carry. There's some ones for bone healing, there's some ones for inflammation, which are just different things they can help take to help curb that pain and help give them relief from that concern of taking too many oxycodone. So again, very simple. It is a little bit pricey at first to start your surgical suite. The C-arm is probably your biggest expense, but again, there's drills. Burs. We didn't really mention Burs. There's lots of Burs that you can get. There are, kind of what we call a short isham. There's a long isham. There is a 3.1 diameter kind of conical burr. There's a 4.1 conical burr, and then there's like Shannon burrs. The short isham, I think, is best for your bunions and your distal metatarsal osteotomies, your Tailors bunions. Long isham, I don't really use much. You would use that more if you were doing some sort of a calc slide. So I have a couple of those, but I can't remember the last time I used one. They're pretty long, kind of a cutting surface, so not used very often. The Shannon I use really for my hammertoes. That's it, because it's such a small bone. The conical burrs are more for grinding, not cutting. So the 3.1 is a little bit smaller. 4.1 is really aggressive. So the 3.1 I will use on chylectomies. I will use it on kind of that first TMT, dorsal exostoses. And then the 4.1 I really only use on Haglunds, because that takes a little bit more work to grind those down. The Burs, you can order them from the same site called McCour Medical. I can put the numbers down in the footnotes, or I'm sorry, the website contact information down in the footnotes. Really big kind of site to get all your minimally invasive equipment. It was started by the spouse of Orlando Nunez, who was, of course, the colleague and associate or partner with Dr. Isham, one of the inventors of minimally invasive. So you can get the books, the burrs, the drills, all that basic stuff, the drapes, if you're looking at. However, I found that you can find some cheaper on Henry Schein. There are Brasslers burrs. You can get a Shannon as well as one that's very similar to the short isham. So you can replace those. The conical ones you'd still need to buy from McCour Medical, because not a lot of places carry those conical ones. Good to have a bunch of those. They can break. They can be a little bit fragile, especially if you're new and you're pushing hard, trying to really grind hard. I've never broken one, so it's difficult, but I would buy a few to have on hand. It's also very wise to buy a second kind of tip or motor, not motor, but kind of the actual drill tip to your that holds the burr, to have an extra one in your bag if you're going to really do a surgical suite in case one fails or fails sterility. It's also not a bad idea to have a second drill. That way, if something's happening with one, it doesn't seem to be working one day, you're not leaving your patient on the table and not able to actually perform their surgery. So I tend to have a backup. I actually have 2 drills. I have 3 of the nose tips. I have 3 of the cords, and I actually have 2 C-arms. I keep one as a kind of in a procedure room for fluoroscopic guided injections, and the other one is kind of my surgery one, but they can be interchanged if needed. For example, we had a period last week where a heavier patient stepped on my x-ray panel and broke it, and it took a good week for the x-ray company to give me a replacement. Actually, they didn't give it to me, they charged me, but to get a replacement. So we used the fluoroscopy as our x-ray when we needed it. So they do come in handy for a lot of things, foreign bodies, if they were to walk in your office. My C-arm gets used a lot. You'd be surprised how much you would use that C-arm for if you had one in your office. Yeah, so not, kind of a short podcast today, but I really encourage you all to start your own surgery little suite, your own little surgical room. There's just so much you can do with it, and like I said, you're doubling your reimbursement, you're halving your time spent doing surgery, and it's simple. It is. Again, just to throw props out there, if minimally invasive, especially a no fixation type minimally invasive, is something you're interested in, I would check out amifasinternational.com, AMIFAS. That's for the Academy of Minimally Invasive Foot and Ankle Surgery. I'm actually their scientific chair. That's why I'm going to throw props out to them. We have a big meeting every February in Orlando, where we have all these doctors come in. We also do a cadaver lab. It's very well done, very well liked. We have lots of vendors from the minimally invasive type community. We're all really cordial. We want people to learn minimally invasive. It is not witchcraft. It's not some crazy thing. It's just, as we know, money drives everything. And in your residency, that's where the Arthrexes come in. The strikers, they help pay for your cadavers. So it's not something you're really going to learn. For me, if this is something you're interested in, you can even reach out to myself. You can come shadow me. You can come see how I do things. I have excellent outcomes with the Bosch. I even have excellent outcomes with the Revert and Isham. So if you'd like to learn more, check out that website. Check out my website, elitefaor.com. Reach out to me by email at drtrev@elitefaor.com with any questions, and I can help you get your surgical suite set up. I can help you go over a case that you might be interested in. I'm open for shadowing. I'm open for teaching. That's my goal. I want people to make money, become wealthy, and be successful podiatrists. And I can show you how to do that. Or you can learn it yourself. It's not difficult. I learned it myself, aside from the minimally invasive. I did learn that from somebody. And I think it's important to have a mentor or somebody to teach you minimally invasive. It's just one more tool in your toolbox to be able to increase your efficiency, cut back at your time spent away from home and your family, and to increase your reimbursement. So once again, thanks for jumping in on the Podiatry Mindshift podcast. Again, my goal is to keep these podcasts less than 30 minutes. We all have things we got to do, places we got to be. Doing a podcast for an hour seems unreasonable. So thanks for tuning in. Join us for our next podcast, where I'll be talking about private equity and their investments in private practices, and how that's affected myself here in Oregon with a new law that's passed, and why I think it's a bad thing versus a good thing. Once again, thank you, and have a great week. We'll see you at the next podcast.